So welcome everyone to today's talk on Ixekizumab, an evolution in the treatment of psoriasis by Dr. Srikumar Gothuru. I am Dr. Hanish Babu chairing today's meeting. Welcome everyone. Dr. Srikumar Gothuru, fondly called as Dr. Sri, needs no introduction to this august audience. Still, as a formality, I would love to do it of course, for the records. Dr. Srikumar is a consultant dermatologist and venereologist trained in renowned medical schools of India, namely the Madras Medical College and Christian Medical College, Vellore. He is an international fellow of American Academy of Dermatology, FAAD. Dr. Srikumar was a gold medalist in dermatology and have presented many papers in national and international conferences. Before coming over to the Gulf, he was a teacher for postgraduate students at Madras Medical College, Chennai. Later, he worked in the Ministry of Health, Saudi Arabia, before joining Dr. Joseph's Polyclinic in Karama, Dubai. That was in 2005. He has a passion for professional presentations and has presented cases and papers in many peer-reviewed fora. He has a special interest in immune-mediated inflammatory conditions and has a number of patients on biologics. He has also organized the Amber Clinic's psoriasis support group in UAE. Now over to today's talk. Ixekizumab, as we all know, is a humanized IgG4 monoclonal antibody that acts mainly by neutralizing cytokine IL-17A. It is a fact that the remarkable results patients with moderate to severe psoriasis with or without arthritic disease achieves, it introduces a paradigm shift in the medical management of psoriasis, where complete or almost completely clear skin becomes the new therapeutic goal for the psoriasis patients. Now, the objective of today's meeting is to understand the difference between the major IL-17 antagonists, Ixekizumab and secukinumab. And as usual, from theory to practice, Dr. Srikumar will share real-life cases from his impressive collection. Dr. Srikumar, I invite you to present this talk on Ixekizumab, an evolution in the treatment of psoriasis. Over to Dr. Sri.
Thank you, Dr. Hanish. It was indeed a great pleasure to be introduced by you. We have been hearing your series of talks on vitamin D and its major role in all aspects of human life, including the immune impact it has and its impact in psoriasis too. It was indeed a wonderful series of talks that you gave, and it gives me great pleasure to be introduced by you. Again, to put it in a nutshell, why me and why you? Why me? I am a practitioner in the Middle East for the past 20 years. I have a deep interest in immune-mediated inflammatory conditions, and I have a large number of patients on various types of biologics for various diseases. And to be frank, having been in practice for nearly 30 years now, the paradigm shift in the way we treat patients is very evident. Not long ago, we used to use medications which were very cumbersome, very smelly, and not very effective. And we were struggling. In fact, as Indian dermatologists, all of you know that psoriasis is one of those things that we never seem to actually have any impact with our treatments. Anything we tried ended up with side effects, but the whole story has changed. Therefore, without wasting more time, let me get into the core subject. Of course, today's talk is about whether all interleukin-17s are the same. It's sponsored by Lilly, and that's the main disclosure and disclaimer for the talk. Our main objective, as Dr. Hanish already mentioned, is to see whether we can differentiate between the different IL-17 molecules. To start, I'll be going through what is the molecular difference that we are talking about. How is it that ixekizumab is molecularly different from the other IL-17s? Does this molecular difference have an impact in its efficacy or safety? Then I will go through a basic few indirect comparisons between ixekizumab and secukinumab, statistically compounded. And then we will go through a few network meta-analysis of efficacy and safety data, and finally conclude with personal experiences, which is actually probably the most exciting part of it. So what is it that we are dealing with? Dr. Hanish already introduced it. Ixekizumab is indicated for adults with moderate to severe plaque psoriasis who are candidates for systemic therapy or phototherapy. This sentence is loaded because, see, the words eligible for systemic or phototherapy and adult patients are key in its license. So what is it? It's actually a humanized immunoglobulin G4 monoclonal antibody that selectively binds with interleukin 17A and inhibits its interaction with IL-17 receptors. Of course, we all know this. It has a half-life of about 13 days, and it's available as a 80 milligram vial, that is in 1 ml, single-dose pre-filled syringes or auto-injectors. Now, this is how the auto-injector looks, and we all are quite familiar with the dosing. We start with the 2 injections, which is the loading dose on day 1, which is 160 milligrams, followed by 80 milligrams every 2 weeks, up to 12 weeks. And after 12 weeks, the injection is given every 4 weeks. And this is all because of its pharmacokinetics and pharmacodynamics. Now, what is it that makes it special? Let's have a look at some of the basic things when it comes to nomenclature of monoclonal antibodies. We know that most of the monoclonal antibodies come with a suffix. If you have a suffix which says OMAB, we are dealing with a fully murine, that is non-human monoclonal antibody. The full amino acid sequence of the antibody is derived entirely from the murine sequence. And that is an OMAB. When we talk about a chimera ends with the suffix ZMAB, like infliximab. Okay, it contains a constant region which is human in origin and a variable domain or domains which is non-human in nature. It is about 70% human. This makes a huge difference when it comes to neutralizing antibody production, when it comes to injection reactions and infusion reactions, and when it comes to how effective it is on retreatment after a break. And when you talk about a humanized monoclonal antibody or a ZUMAB, so most of the monoclonal antibodies, most of the amino acid sequence is human in nature, with the exception of CDRs. What do you mean by CDRs? Complementary determining regions of the DNA, small bits of the variable region, which are of murine origin. So ixekizumab is basically a humanized monoclonal antibody. So this is basically 85 to 90% human with a small component of mouse origin. So this kind of a monoclonal antibody has some special characteristics when it comes to affinity, binding, efficacy, effectiveness, etc. We'll come to that in more detail in a bit. Of course, the final one is the fully human one, which has the suffix of UMAB. The entire amino acid sequence is of human nature, which is 100%. So secukinumab is a fully human monoclonal antibody. Ixekizumab is a humanized monoclonal antibody. That is the basic difference when it comes to the molecule. But that's not the only issue. See, when you look at it in more detail, how is a human monoclonal antibody produced and how is a humanized one produced? See, basically, we are injecting human interleukin 17A into a mouse, and in this mouse, the mouse immunoglobulin G locus is replaced with human DNA sequence. So this is the way that you end up with a human anti-interleukin 17A antibody. This requires modification of the mouse gene. In other words, this is a modified mouse. And this is how a fully human antibody is generated. Whereas when it comes to the humanized one, the mouse still has mouse immunoglobulin G locus, which is intact. After injection of human interleukin 17A, you develop a mouse anti-interleukin 17A, which is extracted, and from that, you take out the CDRs, the complementary defining region, and graft it into a human backbone of immunoglobulin G. Of course, this is a very crude explanation just to differentiate between a human and humanized monoclonal antibody. Now, when we come to the further details, see, the basic way that Taltz and Cosentyx differ, that is Ixekizumab and Secukinumab, is in the following manner. One is an immunoglobulin G4. Ixekizumab is a G4 immunoglobulin, whereas Secukinumab is G1. G4 is basically fragile, but the molecule has been modified to make it pretty stable. And of course, Ixekizumab is humanized, Secukinumab is fully human. The binding affinity of Ixekizumab is far, far higher than that of Secukinumab, which is reflected in the recommended dose, which is much smaller, 80 mg, whereas for Secukinumab, it is 300 mg. The elimination half-life is also different. This is 13 days and that's 27 days. And this reflects in the number of injections during the first year, which is 18 for Ixi and 32 for Secukinumab. The number of injections during the second year is 13 for Ixekizumab and 24 for Secukinumab. So the basic molecular structure of Ixekizumab is definitely different from Secukinumab, and it has a much, much higher affinity to the interleukin 17A. And in fact, we are not talking about a biosimilar at all. We are talking about a molecule which is totally different in its mode of action, affinity, efficacy, and all other profiles. Therefore, we can see that so many patients who might have a secondary failure with the Secukinumab can pretty easily be treated with Ixekizumab, definitely. When you come to the comparison, let us start with some basic indirect comparison of Taltz versus Cosentyx. So how do you do an indirect comparison? So indirect comparisons are pretty simple. You take drug A and then you compare it with drug C, and you take the B and compare it to drug C. What basically this means is most of these medications come after phase 3 trials. And when you do a phase 3 trial, the RCT, randomized controlled trial, usually with a placebo or with the most established basic medication is usually done. And when you have trials of this nature run and you get a license and a phase 3 trial has been completed, you can easily compare two similar trials from one to the other. The simplest method would be a statistical method making an indirect comparison of treatment effects that preserves the randomization of the original assigned patient group. And the method compares the magnitude of treatment effect between two treatments relative to a common comparator, which serves as a linkage or bridge. So suppose Secukinumab has been compared to a placebo, or Ixekizumab has been compared to a placebo. You can definitely see what is the difference when you compare indirectly. And the same holds good when if it is compared to etanercept or ustekinumab too. Of course, this is a very simple or crude way of doing it. And you can refine the process because there may be many confounders. So when you refine it further, you can adjust indirect comparisons by matching adjusted indirect comparison methods. Matching adjusted indirect comparison methods are pretty interesting. So the basic method is called the Butcher method, which is just an adjusted indirect comparison. Whereas in a matching adjusted indirect comparison or the Signorovic method, what you do is extension of the same old principle. Only thing is available individual patient data are also reweighted so that you can get an average baseline characteristics which match between the two trials. So when you do a trial, you take a population, which is the ITT, intention to treat population. These patient characteristics, if they can be matched and reweighted, you can get a better comparison. Of course, the treatment outcomes, including the continuous categorical and the sensor time event outcomes, can also be compared when you balance a trial like this. So let's have a look at how this is done. So what do you mean by matching? So after a clinical expert consultation and a regression analysis is done, and we choose the appropriate baseline characteristics for matching. For example, study A has, which has been published, has this kind of baseline characteristics. If you take the study B, you will find that the baseline characteristics may not match perfectly, but there may be high matching or low matching, but you can apply weights and adjust it. And based on the application of weights, you can get an ESS or an effective sample size. And then you can recalculate the whole outcome and you come to your new data. So this is basically the method. So let's have a look at some of the indirect comparisons between ixekizumab and secukinumab using matched adjusted indirect comparison. So this is one of the studies. If anybody wants to read it, this is the reference. And let's have a look at how exactly this was done. The inclusion criteria and the statistical methods are shown, the basic ones. The induction period, the ITT, that is the intention to treat population for fixture and uncover 2 and 3. The fixture 1 is the secukinumab, and uncover 1 and 2 and 3 is for the ICSI. So inclusion criteria are adult patients aged 18 years and above. All of them had chronic plaque psoriasis of more than or equal to 6 months duration before randomization. Phototherapy and systemic therapy they were eligible for definitely, and moderate to severe psoriasis as defined by a BSA of more than 10 or a IGA or PGA of more than or equal to 3 and a PASI of more than or equal to 12. Of course, the two previous methods that we mentioned were used, the Butcher method or the Sigorovic method. Now, indirect comparisons of the PASI and DLQA were the primary endpoints of these studies. The indirect comparison can be actually, the PIDs, the data can be adjusted, weighted for the total population or even for separate arms. So you have actually 3 ways in which it was calculated. So this is the study design. So you can see the fixture design where secukinumab 300 mg once weekly and 150 mg once weekly, etanercept 50 mg twice weekly, and a placebo was used, and then randomized into these. Whereas in the other side, you find ixekizumab Q2 weeks, Q4 weeks, and of course, etanercept 50 mg twice weekly, and a placebo being randomized. And then using the methods, we extrapolate the data, and we get our indirect comparisons. So this is the PASI response by treatment week. This is a non-responder imputation, which is quite a harsh way of looking at it. That means the patients who were lost to follow-up or data not available were considered as non-responders. The induction period, the ITT population for fixture and uncover 2 and 3. Ixekizumab Q2 weeks treated patients achieved greater PASI response rates versus etanercept and secukinumab 300 at week 12. So this is the clear-cut data, which shows you that the PASI 75, the differences between ixekizumab, secukinumab, and etanercept, the PASI 90 figures and the PASI 100 figures by week 12. You can see quite a significant difference when we come to the PASI 90 and the PASI 100, be it a basic indirect comparison or the matched adjusted variant. This is a forest plot. Forest plots are pretty interesting. You have the central dotted line, which represents the null hypothesis, which says that there is no basic difference between the two comparators here. The right half is the one favoring ixekizumab, the left half, this one is the favoring secukinumab. And these are all the various studies which have been further split into the basic Butcher type of study or the Sigorovic total or the separate ones. Here is the DLQI represented PASI, PASI 100, 90, and 75. You can easily see that PASI 100 and PASI 90 are significantly, definitely statistically, clearly significantly superior as compared to secukinumab. When it comes to PASI 75 or to the DLQI, it is almost touching the midline, which means it's almost similar. But definitely by week 12, there's a clear-cut superiority when you are talking about PASI 100 and PASI 90, which is basically what we are targeting at now. We are blessed in the sense that we are in a position where we can actually give a huge difference in the quality of life and the clearance that we can achieve for our psoriasis patients nowadays. And our aim is definitely PASI 90s and 100, a clear or near clear nowadays, and no longer PASI 75. And this forest plot clearly demonstrates the superiority when it comes to the new treat to target with Ixekizumab. So let's go to the next matching adjusted indirect comparison of efficacy in patients with moderate to severe plaque psoriasis treated with Ixekizumab versus secukinumab. This is another trial that you can look it up. This is also something that was used to compare the efficacy and quality of life during the first 12 weeks of treatment with FDA approved doses. All these trials are approved doses and they are trial data. None of them are practice data, which I will come to in the end when I talk about my own cases. And the comparisons included placebo, etanercept, or ustekinumab also. In this, you can see how it was done. Response of Ixekizumab compared to secukinumab in moderate to severe psoriasis, adjusted and matched adjusted indirect comparisons in overview. The objective is to assess treatment and effect differences between Ixekizumab and secukinumab in moderate to severe psoriasis through week 12 using indirect comparison methods. The methods and analysis has been mentioned here. Placebo, etanercept, and ustekinumab, and the various the phase 3 trials which have been utilized in this indirect comparison, and how it was done, the Butcher method, the Sigorovic method, and how matched adjustment was done, which characteristics were matched and adjusted, the age, the sex, the weight, and the duration of the psoriasis, the BSA affected, whether they were on previous systemic treatment or whether they had previous biologic treatment failures. All these were matched and adjusted. So risk differences between Ixekizumab and the comparison was calculated with, of course, 95% confidence interval. A meta-analysis was performed. Okay. Now, how exactly was this done? So Ixekizumab versus placebo, uncover 1, 2, 3. Secukinumab with placebo fixture, eraser, juncture, and feature. Uncover 2 and 3. Ixekizumab comparing to etanercept. The clear study between secukinumab and etanercept. These were all published studies and they have all been indirectly compared. This is how this study has been done. And of course, when you come to ustekinumab, the Ixora study between Ixi and Usti, and the fixture study between secukinumab and ustekinumab was utilized. Now, let's come to the data. Now, the response of to Ixekizumab compared to secukinumab in moderate to severe psoriasis, when you talk about adjusted indirect comparison using the Butcher method, that is 75 PASI 75 results in non-responder imputation calculation, has been depicted here. You see this color is for secukinumab and the darker blue one is for Ixekizumab. You see by week 12 the PASI 75 difference between the two when you compare it to the placebo. PASI 75 when you compare it to etanercept. The PASI 75 when you compare it to ustekinumab. There is a superiority when you look at Ixekizumab as compared to secu in almost all of them. When you talk about PASI 75, maybe the difference isn't major, may not be statistically significant. But definitely when you compare the PASI 90, you start seeing the delta, you start seeing the differences. PASI 90, there's the clear-cut superiority when you look at Ixekizumab, when you compare with placebo, etanercept, or ustekinumab. And you can also see similar difference when you talk about PASI 100, whether it is placebo, etanercept, or ustekinumab. Of course, when you compare to ustekinumab, possibly ustekinumab, because of its basic pharmacokinetics and dynamics, you might need a week 24 comparison too, but that's a different issue. So let's have a look at the key results that we have been going through. The response to ixekizumab compared to secukinumab in moderate to severe psoriasis using adjusted and matched adjusted indirect comparisons are the following. When you use the Butcher and the Sigorovic analysis, it showed that PASI 75 and PASI 100 responses relative to etanercept were statistically significantly higher in the ixekizumab versus secukinumab studies as early as week 2 itself. In other words, ixekizumab starts showing much better results by week 2. PASI 100 response relative to etanercept was statistically significantly higher in ixekizumab versus secukinumab as early as week 4. So you start seeing much faster results and much higher responses at early stages when you talk about ixekizumab. When you come to week 12, PASI 75 risk differences were modestly higher for ixekizumab versus secukinumab for all analysis methods used. However, only the Butcher method demonstrated statistical significance. In other words, PASI 75 seems to be more or less similar. The PASI, when you come to week 12, the PASI 90 and the PASI 100 risks differences were statistically significantly higher for ixekizumab versus secukinumab for all the methods used, that is via whether you talk about etanercept or the placebo or two. The risk differences when you talk about the DLQI, that is DLQI achievement of 0 and 1 response, was generally similar between ixekizumab and secukinumab. So these are the key things that we learned. So faster response and a much higher response at an earlier stage and definitely by week 12. Now let's have a look at the drug survival. One of the things that is of interest to us about how effective a drug is, effective in the sense that how much it can clear, and how effective it is in the sense that the patients are able to take the drug for as long as possible without dropping out because of side effects. So this is drug survival. When you look at drug survival data, we get an indirect idea about how effective a medication is. So let us look at some of the drug survival data from the Derm Bio registry. So drug survival of interleukin-17 inhibitors. The aim of this study is to investigate the drug survival of interleukin-17 inhibitors, that is secukinumab and ixekizumab. The methodology used were patients were enrolled between April 1, 2015 and August 1, 2018. They were treated with ixekizumab or secukinumab for at least 52 weeks. This is not a 12-week study. This is a 52-week study of survival, drug survival. And these were included in the study. These are all data, registry data. Okay. So 368 patients were included for the secukinumab. 40.7% were bio-naive, and 62 patients were included for secukinumab, out of which 12.9% were bio-naive. This is an important point because there seems to be a big difference in drug survival when you talk about a bio-naive and a bio-experienced patient. The mean number of previous biologics used was 1.3 for secukinumab data and 3.6 for the ixekizumab data. Kaplan-Meier plots were used to present a descriptive or unadjusted survival curves, that is stratified into bio-naive or non-bio-naive patients. The limitations of the study was the low number of patients, especially for ixekizumab, and a short-term follow-up. Of course, even with this data, the conclusion is that drug survival was higher with for ixekizumab, even though ixekizumab-treated patients had received significantly more previous treatments. So let's have a look at the data itself. So the drug survival in this and the weeks, X and Y axis. And you can see that when you talk about bio-naive patients, ixekizumab has a very huge drug survival when you talk about week 52 data. Even secukinumab seems to have a good survival in the bio-naive patients. But once you come to the bio-experienced patients, drug survival drops down pretty fast for secukinumab, whereas in ixekizumab group, it seems to be still better. So clearly, the survival of patients on ixekizumab for a much longer time for the psoriasis patients on ixekizumab can be seen with this data. So let's go into some more network meta-analysis data. See, network meta-analysis or indirect comparisons are done when you have a huge number of trials and a huge number of medications to be compared. As experienced dermatologists, we have all used methotrexate, we have all used cyclosporin, we have used phototherapy. Some parts of the world, they use turmeric acid. The systemic therapies have been around for a long time. And many of us have used the older generation biologics, be it etanercept or adalimumab or even for that matter, Ixekizumab. So now we have a huge plethora of data with the new biologics also, kids in the block, interleukin 17s and the interleukin, purely interleukin 23s. So with so many medications around, when no head-to-head trial between two interventions are available, a network meta-analysis or indirect comparisons is what we go for evidence-based medications. So network meta-analysis provides simultaneous analysis of networks involving more than two interventions. Excuse me. Adjusted indirect comparisons, at least two trials investigating the magnitude of treatment effect between two treatments relative to a common comparator, that is placebo or a standard treatment, is required to be a participant in this kind of a network. Of course, one of the quantitative evaluation of biologic therapy options for psoriasis, systematic review and network meta-analysis, Jaber, Lopez and all, you can definitely go through this article if you want. The objective is to assess efficacy and tolerability of licensed therapies for skin psoriasis. Adalimumab, etanercept, infliximab, secukinumab, ustekinumab, ixekizumab have all been compared with each other and with placebo, methotrexate, and also to rank the biologic therapies in terms of combination of both efficacy and tolerability. So this was done to inform the development of the BALD guidelines for the use of biologic therapies for psoriasis. This is a detailed write-up about when it was started and how patients, which kind of studies were included and the statistical analysis. I won't go into this in detail. And again, the various ways that they filtered out the studies based on the bias and how they used matching and other means to arrive at the data. And this is a look about the SUCRA, that is the surface under the cumulative ranking when it comes to the various medications that were studied in this network meta-analysis. And you can see the rank that ixekizumab has with nearly 96.4 when it comes to PASI 75 as compared to secukinumab, which is also not bad, which is around 79. So clearly, when you look at the various medications studied here, and especially when you come to the near clear or clear, the PASI 100 data and all that, you can see the clear superiority of ixekizumab. Of course, this is a 2017 data, the Jaber-Lopez study, and it was published in the Journal of Investigative Dermatology, ranking based on the clear or near clear response surface under the curve of response cumulative ranking data. You can see that based on clear or near clear response, ixekizumab was ranked as the most effective treatment with a 94.5% probability, followed by secukinumab. Ixekizumab was also most effective based on PASI 75, followed by infliximab. And secukinumab was most effective for mean change in the LQA, followed by ixekizumab. So you can see the high ranking that ixekizumab has in this data. Comparative effectiveness of targeted immunomodulators for the treatment of moderate to severe psoriasis. This is the loose study The objective is to evaluate the comparative effectiveness of targeted immunomodulators and to describe the short-term adverse events that occurred in at least 5% of the patients and longer-term adverse events for the newly targeted immunomodulators. So let's have a look at the data. And of course, again, the various inclusion, exclusion criteria and the statistical methodology and the details of the population study and other things. And the data per se, where you can see the PASI 50, PASI 75, and PASI 90. Let's look at the PASI 90. You can see the infliximab data with its confidence interval. You can see the ixekizumab data. Ixekizumab shows the highest PASI 90 response. And you can see the range of these molecules. Again, ixekizumab was ranked the most effective treatment, followed by brodalumab. Ranking based on PASI 75 versus placebo relative risk with a 91% confidence interval.
Unmuted.
Ixekizumab, brodalumab, and infliximab were all statistically superior to ustekinumab, adalimumab, and etanercept, and apripilast, but not relative to each other. Results were similar to those of available head-to-head studies, except for the CLEAR study. And we will go have a look at some of the other data. This is the Chui et al. Study, efficacy and safety of biologics targeting interleukin 17 and 23. Meta-analysis to indirectly compare short-term efficacy and safety of biological agents targeting IL-17 or its receptor, that is brodalumab, and IL-23 treatment of moderate to severe plaque psoriasis. Again, the inclusion and exclusion criteria for this meta-analysis and statistical methods. And the data, let's look at the PASI 90 data. You can see the efficacy data in PASI 90 with the relative risk of falling in that range. You can see, let me see, ixekizumab has the highest response rate by week 12 to week 16. Here is the ranking according to efficacy. Ixekizumab Q2 weeks had the greatest probability of achieving both PASI 75 and PASI 90 response at week 12 or 16, followed by ustekinumab and secukinumab. So this is a 2018 study. Now, we are all aware of the Cochrane database and the way that various registries and trial data are put into these databases. And in fact, the 2020 Cochrane database is very much live even now, and the data is changing almost on a daily basis. If you look at the 2020 Cochrane database, you may be able to see the changes that have happened from 2017 to 2020. So if you look at the 2017 data, ixekizumab was ranked the most effective treatment, followed by secukinumab. Infliximab, surprisingly, is in the middle of the field in this, whereas it moved to the top position in the 2020 data update, which is probably a reflection of which kind of studies have been analyzed in the 2020 database. Again, a very interesting plot of the PASI 90 and the serious adverse events of the various biological agents. The most effective one would be one which is highly effective, which produces a very good result with minimal serious adverse events, obviously. So we are in a blessed era when we do have agents of this type. And when you look at this Cochrane database of 2020, you can find that ixekizumab has a high ranking in this. Actually, infliximab comes here, but still, ixekizumab seems to have the highest combination when you talk about effectiveness. And when you talk about the comparison of serious side effects to the PASI 90, you can actually see some interesting graphs. So you can see here the serious adverse effect as compared to the PASI 90 with all these medications. And when you talk about tolerability, see, adverse event and acceptability are different ends of the spectra. Acceptability of a molecule is a reflection that the incidence of serious adverse effects are very low. So when you look at a plot like this, it looks pretty interesting. You see where methotrexate is, and actually this is a data which has been shown by many people, where you will find that, for example, the IL-23s and even bimekizumab seems to be having a very high efficacy with very low side effects. And when you look at data, for example, infliximab or ixekizumab and these molecules, secukinumab, etc., they seem to be almost similar or even more effective, but they plot a little bit lower on the serious adverse effect. This is very strange and interesting. And actually, the look at where methotrexate stands. We have all used methotrexate for a long time, and we know that when you use methotrexate, by and large, most of the data for methotrexate seem to have come after the biologic era, because almost every company which is coming up with medication seems at some point of time or other trying to compare it to methotrexate. And many of the trials of methotrexate are seen only after the biologics have actually come up. And we know the serious side effects that patients with methotrexate might have, but see where it stands. Therefore, how do we actually analyze this in more greater detail? So the detail comes in the number of patients, the number of events, and how exactly it is analyzed. In general, we know that the effectiveness, the PASI 90 efficacy is calculated with a huge number of patients. In general, we need to be very cautious when interpreting safety and tolerability data in network meta-analysis, because these analyses are based on very low number of events. When you talk about side effects, when you talk about the side effects, incidence of side effects, basically 5% or more would be considered as common. Anything less than that would be uncommon. When you look at the serious adverse event of any of the biologics which are licensed and in use right now, the incidence of serious adverse events seem to be pretty low. Of course, we are not trying to say that it is zero. Definitely, we are all practitioners, we are all taking risks, and we have to counsel patients. But then, even as compared to placebos, most of the time, these medications, serious adverse effects seem to be much less. And when you look at this minute number of patients who end up with these serious side effects, what's more, inconsistencies across the definitions of these safety outcomes also are there in the various trials. And also the collection time points, when this side effect occurs. Is it during the induction phase? Is it during the maintenance phase? Or after how long? And all these things complicate the analysis of the interpretation. And when you look at actually the safety data, we found no significant difference between any of the interventions and placebo for the risk of serious adverse event, which is what I already spoke to you about. Nevertheless, the serious adverse event analysis was based on very low number of events and with low to very low certainty for just under half of the treatment estimates in total and moderate for the others. So another major concern is that short-term trials provide scanty and sometimes poorly reported safety data, and thus do not provide useful evidence to create a reliable risk profile of treatments. Indeed, we found no significant difference in the assessed interventions and placebos in terms of serious adverse event, but the evidence for all the interventions were of very low or moderate quality. So, thus, the results have to be viewed with caution, and we cannot be so sure of the ranking definitely. So, in order to provide long-term information on the safety of the treatments included in this review, it will be necessary to evaluate non-randomized studies, including post-marketing reports released from regulatory agencies. Therefore, the jury is out when it comes to the safety data. And the truth is, most of the molecules seem to have a relatively safe profile. At drug levels, in terms of reaching PASI 90, infliximab of all of the IL-17 on all of the IL-17 drugs, Ixi, Seku, bimekizumab, brodalumab, and all the IL-23 drugs, risankizumab, guselkumab, but not tildekizumab, were significantly more effective in reaching PASI 90 than UST. And the 3 TNF-alpha agents, adalimumab, certolizumab, and itanacib. This basically means that the newer generation IL-17s are the newer generation pure IL-23s are far superior to the older generation molecules. And network meta-analysis also showed that infliximab, ixekizumab, risankizumab, bimekizumab, guselkumab, secukinumab, and brodalumab outperformed other drugs when compared to placebo when reaching PASI 90. Conservative interpretation is warranted for the results of bimekizumab, fumaric acid esters, and methotrexate, as these drugs in the network meta-analysis have been evaluated in far fewer trials. Of course, we don't have so many trials with these agents. And now let's have a look at the rapidity of response. Rapidity of response of biologics in a disease like psoriasis, which can run lifelong, is this really important? To be frank, it is. See, what gives us more thrill than anything nowadays when you can actually improve a patient in the blink of an eyelid, to be frank. The rapidity of response that we are getting nowadays is really fantastic. And not only that, it plays a crucial role in many patients who suffer from, for example, an erythrodermic psoriasis, who are in a metabolic crisis, or who are having a severe arthritis, a combination of both. So there are situations when the rapidity of response is definitely something to be considered. So let's have a look at a network meta-analysis where the objective is to look at PASI DLQI responses at early points, less than 12 weeks of treatment for biologics used for the treatment of psoriasis. And the methods data collected is PASI 75, PASI 90 response week 2, 4, 8, 12, DLQI 01 responses at week 12, and the biologics which were compared, brodalumab, ixekizumab, secukinumab, and the IL-12-23, ustekinumab, and the pure IL-23 inhibitors, and the TNF inhibitors too. Analysis was done with special methods like Bayer's NMA, using both fixed and random effect normal independent models, statistical methods, which I won't go into. And of course, it was analyzed even further for sensitivity too. And let's look at the network. The bigger the dot, the more the number of patients in the study. Of course, placebo will have the biggest dot because almost all the molecules have been compared to the placebo. The older a molecule is, the more the number of studies. But see, the number of studies that secukinumab and Ixi also are quite considerable. And you can see the number of trials which were used in the network meta-analysis, which was used to generate this data. And you can see the results. Ixekizumab and brodalumab ranked highest for PASI 90 response network meta-analysis treatment ranking by PASI 90 response at week 12. Okay, so you can see the rapidity of response and reaching high levels. The rapid response to biologics in moderate to severe psoriasis network meta-analysis showing the treatment effects of DLQI 0 and 1 response at week 12. You can see that again, the average relative treatment effect was the greatest for ixekizumab and brodalumab. And if you look at the data with the confidence interval, you can see that Ixi is almost the most effective by week 12, of course. Another method of looking at whether we are reaching our target, which is pretty high nowadays. We are no longer looking at PASI 75, forget PASI 50. We are looking at near clear or an absolute PASI of 3, or we are looking at PASI 90 definitely. So number needed to treat to achieve this treat to target is a very, very, very important and simple statistical method, which tells us how good or effective a medication is. And when you look at a ranking based on the number needed to treat to achieve a PASI 100, you forget the PASI 90, you see ixekizumab Q2 weeks, 2.49. Look at all the other molecules, the Ixekizumab, Brodalumab, Guselkumab, Secukinumab. Look at Infliximab. So this group is by and large far superior to this group. So the number needed to treat, the number of patients needed to treat for one patient to achieve a stated outcome, you will see a PASI 100 by the time you treat 2.5, in fact, less than 2.5 patients, 2.49 patients with Ixekizumab. So that's quite an exciting thing. This is what the data has shown us. But forget data. The data has been all shown from various network meta-analysis, and there may be so many things to be considered when we look at data. But let's have a look at what we see in practice. In fact, it gives me great pleasure to share some of my personal cases. And this is an area where I'm pretty free to talk, because this is my own experience. And when you talk about practice, I have probably nearing 30 patients on Ixekizumab now, and maybe even 50 and above for Secukinumab. I have touched almost 100 patients on various biologics for psoriasis and crossed it now. And we are blessed in that sense. And we do have a huge number of patients currently on various biologics. And it's a pleasure for me to share just a few cases. One of the first cases I would like to share is an erythrodermic psoriasis. You know erythrodermic psoriasis, the entire body was red, swollen, scaling. He had metabolic complications. The patient was shivering. He had to be admitted in hospital. He had a multi-domain involvement. Nails, scalp, palms, and soles were involved. And after admission, he was actually initially started on cyclosporin, which he could not tolerate, and he had some side effects, and actually he got discharged. And the story was that actually 3 of the dermatologists, maybe they are also in the meeting right now, participated in his care before we finally ended up starting on Taltz. See the difference, see the smile, see the impact that we can create in a patient's quality of life. This is a young man who has come to Dubai as an expat, who has come for his livelihood. Like this, where is his livelihood? He had lost his job. He was sitting at home. Now he's got back his job. He's got back his livelihood, and he's got his smile back on his face. Let me tell you that even though I have not exactly in this presentation shown the response at week 2, week 12, etc., with Ixekizumab, when you give the first 2 injections, the 160 mg injections, and when they come for the second injection by week 2, you will see a difference. And then you see a difference by the time you finish the 12 weeks, you will find quite a huge difference. And you can see that the difference is not only on the skin, but you can see the huge impact it has on the scalp. Look at the scalp of this patient. Thick, red, scaly, cracked plaques. And look at this, it's almost cleared up. Look at its trunk, and look at the nails. Look at the subungual hyperkeratosis. Look at the splinter hemorrhages. Look at the leukonochia. Look at the onycholysis. Look at, you can clearly say that his NAPSI is very high. And look at the very clear nails that he has achieved. Of course, this is not in 2 weeks. This is not in by week 12. This took a little longer. But see the impact the disease has on the quality of life and the clearance that it has achieved. And look at his palm, the thick psoriatic plaques and the cracks and all that. And look at his palm now. It is almost totally cleared. This is a nearly PASI 100 or a near clear response in a patient. And I have had this patient on treatment for almost 3 years now. So fantastic response, rapid response, near clear response, and absolutely sustainable. I didn't have any problem with injection site reactions or pain. He is absolutely comfortable taking the injections. Of course, his insurance did have some problems initially, and he's on the support program. The company will tell you individually how the support program works and how it can be used in patients who are in need. we are obviously talking about a medication which we are going to give only in the needy. This is absolutely needy patient who has an erythrodermic psoriasis, where we are in need of a rapid response. The rapid response and the response in multiple domains and rapid stabilization and the sustainability of this has been demonstrated in this patient. And it's a personal experience, and it actually begs the question, isn't this molecule the drug of choice when it comes to rapid response? My answer would be definitely yes. Of course, all the IL-17s are pretty fast, but still, I would say that Ixekizumab made a huge impact at a very, very early stage. Let me talk about a few more cases. The second one is a 38-year-old male executive who had psoriasis for 6 years duration, classical sites, but also genital, groin, and natal cleft. He was married, but he was having a huge psychological impact because of the genital involvement, groin involvement, and all that. And the interesting thing about him was the fact that he was a TB gold quantiferon positive. He did not have any clinical signs of tuberculosis, no low-grade fever, no weight loss. ESR was okay, and chest X-ray was okay, sputum was okay. There was no clinical tuberculosis. Hepatitis B and C, of course, HBsAg alone is not enough. For hepatitis B, you need to do the core antigen also. All other things were negative. And he had no vaccinations due. His BMI was this, and he did not have any bowel issues. And of course, I put him on Ixekizumab, and I'll share the photos. Look at the complete clearance in the buttock, in the genital areas, in the natal cleft. It took a much longer time in the shin and in the leg, where post-inflammatory pigmentation did last for a bit longer. This is definitely a fact. And my observation is that I have had, being an Indian doctor who has a lot of patients with latent tuberculosis, the new IL-17s and 23s probably are pretty okay when it comes to latent tuberculosis. Of course, as per the label, we are supposed to put them on medication for latent tuberculosis. But even in patients who don't take it, we have never seen any latent tuberculosis being reactivated till now with these agents. And the excellent response in genital psoriasis and other areas you can see. My third case is pretty an interesting case. This actually was a psoriatic patient who had an arthritis, both axial and peripheral arthritis. So he had a spondyloarthritis and also had a distal interphalangeal arthritis and palmoplantar and nail involvement. In other words, all the domains that the IL-17s and Ixekizumab work in. And he had, interestingly, he did respond to adalimumab. Originally, after a failure with methotrexate, I had convinced the insurance company and managed to get him adalimumab, and he did respond to adalimumab. Both the arthritis and the skin responded to adalimumab, and he had a PASI 75 response. But what happened was he missed a few injections. And with adalimumab, if you miss a few injections and then you restart, you do not see the same kind of response that you see when the patient was first on this medication. So finally, he ended up with a secondary failure with adalimumab. And I started him on Ixekizumab, and a rapid and sustained response was observed. And the interesting reason, or the story, the reason I'm talking about this case is that he had a confirmed COVID in March 2020. So what actually happened was, these are before and after pictures after Taltz. Look at the nails, look at the massive improvement in the nails, look at the clearance that you can see, look at the dactylitis, look at the shrinkage. There was no pain. At this point, he had pain and tenderness. There's no pain or tenderness. Look at the toenail also, which has cleared a lot. So all domain improvement. Look at the sole. Look at the impressive improvement in the sole. A little bit is there, but still, there's a massive improvement. And look at the soles again. The reason I actually was tempted to talk about the case was that the point of interest was that On 5th March 2020, he underwent a RT-PCR for COVID, actually as a routine, as part of his employment. And then actually he was on his monthly injection Taltz. The test was done on the 5th of March, and on the 10th of March, he took his 80 mg monthly injection, subcutaneous, at his house on his own. And then, surprisingly, on the 11th, he got an email from the ministry that his COVID-19 test was positive. Of course, initially he panicked and immediately called me. I told him that, look, do not panic, and of course, do not continue the medication. I strictly stopped him from continuing the medication further. What actually transpired was that he had a mild cold for about 2 or 3 days. He used to call me up and talk about it. And then he absolutely recovered. For 15 days, he was at home. And then he kept pestering his company, and he kept pestering for a retest. They didn't accept a retest for him till about a month later. And then after 1 month, his COVID test turned out negative. I was speaking to Professor Lebhol in the US, and he advised me actually wait for 2 COVID negative tests before you restart him on the molecule. I advised him for a re-test also, but that was a time when there was a huge demand for the tests, and the government refused to do a repeat test for him. After 1 more month, he went back to work. To cut a long story short, after a gap of 3 months, he finally restarted Taltz. And he's now continuing his monthly injections of Taltz, and he's doing pretty well. And I have not faced any issue at all with him. And to cut the whole story short, the response that I have seen in my day-to-day practice, like I said, nearly 30 patients I have on Taltz. By week 12, easily a huge number of them do have a PASI 100 response. You find a huge number of them clearing up quite well. And the rapidity of onset, like I said, even after the first injection itself, you will find that a huge difference is there. When they come for the second week 2 injection, 52% easily will have average PASI improvement is almost 52. There's a clear difference. And it's easily sustainable. My oldest patient is almost 3.5 years plus now on Taltz. And the sustainability is definitely not an issue. The only practical issue is that some patients, they stop injections due to various reasons, due to travel, etc. But otherwise, on a patient who is actually compliant, sustainability is not an issue at all. So, of course, Taltz is now approved.
Thank you, Dr. Srikumar, for a comprehensive talk on Ixekizumab. It's always a pleasure to listen to you. Now,
thank you,
floor is open for questions. Dr. Anisha, after how many weeks do you ask them to self-inject?
That depends on the patient's comfort level. Excuse me. The main difference between secukinumab and ixekizumab, for example, is that once you learn how to take the injection, ixekizumab, use an ice pack or something to numb the area, and then choose the right location to inject and all that. It's not at all difficult. Nowadays, most of my patients, only the first injection they take under supervision. After that, they are pretty comfortable to take it on their own. But this is actually highly individual. Some patients prefer to come and take it almost every time. But then the majority, I don't see this issue at all.
I think Dr. Mohan Kumar, he has got patients on Cosentyx. He's asking whether he can change to Ixekizumab. And in that case, what are your advices, Dr. Sri?
Sir, common sense, sir. If the patient is doing well, if the treat to target has been achieved and it is being maintained with one molecule, we never change. Of course, if for any reason there is a secondary failure, definitely, as you saw, it's not like you need to change from one molecule to the other. Ixekizumab, even though it's an IL-17, it's humanized, its affinity is far higher, and it has been proven to be highly effective in patients who have had a secondary failure with secukinumab. Therefore, if you do come across a patient with secondary failure, definitely you can shift to ixekizumab. But it's not as if that we go around changing in a patient who is stable and who's doing well.
Yes. From Dr. George Jacob, one concern is the cost and affordability. Of course, insurance can be helpful. He wants some information on biosimilars, if any, which are effective in treatment of psoriasis.
Biosimilars now for the older molecules like adalimumab and infliximab, they are available, sir. The only thing is, as dermatologists, let me tell you that maybe the Ruma gang is still fond of adalimumab or even infliximab. But for us, with the advent of the newer IL-17s and the IL-23s, pure IL-23s, these are far superior in the speed of response, the treat to target achieved, and are easier to maintain, and the side effect profile is much better as compared to the older molecules. So except in a situation where for some economic reason a patient needs to be put on the older molecule, I wouldn't consider going to the biosimilars of TNF alphas, for example. I don't think any biosimilars for the newer molecules are as yet available. But there may be situations where somebody who's on one of the older molecules and doing well wants to shift to a biosimilar, and in that case, it's easily available here. So, in fact, you can substitute for a TNF alpha blocker easily. That's not an issue at all. Of course, when it comes to for the economic part, the patient affordability, the insurance support and all that, the company will definitely support you. If you do have a patient who deserves a medication like Taltz, you can always contact them and they will guide you on how exactly to go about it.
There is one more question from Anisha. Are injection site reactions common? What are the minor side effects you're seeing?
See, when you talk about minor side effect, obviously upper respiratory infections are one of the most common side effects. Per se, upper respiratory tract infections are common in the community, and therefore it's obvious that that would be a common side effect. Injection site reactions have been documented with Ixekizumab, and there have been a few cases where, for example, in the second or third site where you inject, you may develop a reaction in the previous sites also, but that is extremely rare. To be frank, I have more than 30 patients now, and almost nobody has any injection site reaction per se. Pain, if unless you teach them properly how to take the injection and to use, you need to know how to maintain the injection at 8 degrees centigrade in the fridge, and then take it out and warm it for half an hour before using it, and how to numb the skin with an ice pack, and then how to actually inject it in the proper location, not on a psoriatic plaque. Once you know the technique, the pain is not a major issue at all.
Thank you, Dr. Sri. Dr. Pillai asks, what are the chances of relapse if one stops injection Taltz by any chance because of financial problems or not covered by insurance? In that case, how will you go about it? About treating the patient?
Sir, that's interesting, sir. Like all of you are experts, you know. None of these injections can be classified as a cure as of now. You can maintain the response as long as the patient continues. Of course, the 5 times the half-life for this is 13 days. If they cross 5 times the half-life, the chance that there's a relapse is always there. Some of my patients have missed a few injections and then restarted on the same dose, for example, the monthly dose, provided it is less than 3 months. And then we can maintain it, reclaim the old effectiveness. And some patients, if they miss more than 3 months, probably need a induction dose, that is restarting the 160 mg followed by a biweekly injection. And that is the reality when you talk about any biologic for that matter. There is some data with the newer biologics that maybe the effect we achieve can last for a longer time. That is probably based on the dynamics, that is the pharmacokinetics and dynamics. But then The truth is that any of the biologics for psoriasis are basically lifelong treatments.
Yes, about vitamin D, Dr. George Jacob has asked. So
I think
when
you're a better person to answer, sir.
when you are starting the patient on biologics, do you really for vitamin D?
I'm recommending vitamin D for almost all my patients, at least a maintenance dose. Some of them who actually end up doing a vitamin D test, I would definitely say the psoriatic population has very low vitamin D. If you actually do a vitamin D test in your severe psoriasis patients, it is probably far less than the general population. Of course, I have not personally done for everybody, because as it is, we struggle to do the most important tests that are required for the treatment point of view. So invariably, I do talk to them about diet, and they are all on vitamin D supplementation. Some of them do the test also, and then based on the lower levels, we do treat. After having listened to Dr. Hanish, I would probably be doing a few more tests nowadays and see whether they achieve an optimum level. It was 50 nanograms, isn't it, Dr. Satish? I mean,
40 to 60.
Yeah. That's why I said you are probably the better person to answer this.
Actually, there are a lot of studies now coming out pointing out towards the exact role of vitamin D in autoimmunity. Okay. And vitamin D is proven to be a regulator of the cytokines. So naturally, when we are putting the patients on the or Taltz and other biologics, when we withdraw the medicines, or once the patient is tapered off the biologics, we have to always advise the patients to maintain their vitamin D levels. Not only vitamin D, all other vitamins, as we have talked during the my talk on vitamin D. Vitamin D cannot work alone. It works in coordination with other vitamins, as well as essential minerals like magnesium, zinc, selenium, and of course vitamin C, vitamin K, and other vitamins. So it is very essential that we advise the patients on biologics to continue a healthy lifestyle and see to it that their vitamin and essential nutrients are in proper optimal levels.